All right, listeners, buckle up for a deep dive today, one that's, well, tailored just for you. We're going to be cracking open a medical mystery all about a patient who had VATS, that's video assisted thoracoscopic surgery, for those who haven't encountered it yet.
Yeah, it's a fascinating procedure. Really changed the game for chest surgery.
Absolutely. Now, our listener here, they've shared some notes about this patient, but there's a catch. They haven't told us exactly why the patient needed VATS in the first place. It's like a puzzle with a few pieces missing.
Ooh, I love a good medical mystery. What kind of clues do we have to work with?
Well, we know the patient has those classic VTS scars, three of them right there on the right side of the chest. But here's the thing. Lord breathing sounds perfectly normal now.
Hmm. So something's going on in there, but it seems to be resolved. All right, let's put on our detective hats and get to work.
Exactly. And thankfully, I've got our medical expert here to guide us through the ins and outs of VTS.
Happy to help decipher the clues.
Ah,
Where should we start?
let's start with the obvious, those scars. Three of them, right on the right side of the chest. Classic VATS.
Yeah, pretty much textbook. See, VATS is all about minimizing the trauma. Instead of one big incision, surgeons make a few small ones, just enough to slip in a tiny camera and some specialized instruments. They can operate inside the chest without opening it up wide.
Keyhole surgery for the lungs, essentially.
Precisely. Less pain, faster healing, fewer complications. VATS has really changed the game.
Compared to the old way, I mean.
Oh yeah, way less invasive than open thoracotomy. That's the traditional method where they make a large incision to access the chest. With VATS, patients usually recover much quicker, shorter hospital stay.
Okay, so less pain, faster healing. VATS sounds pretty amazing, but I'm guessing there's got to be a catch, right? There are always trade-offs.
Well, one potential downside is that there's a slightly higher chance of, well, the problem coming back. Say if they used VATS to treat a collapsed lung, there's a slightly higher risk of it happening again compared to open surgery.
Interesting. So a little bit of a gamble, but with some pretty big potential benefits.
All right, so we know VATS is a pretty safe bet, but this is a procedure done on the lungs, right? Why are the patient's breath sounds totally normal now? Should there be, I don't know, some sign that the thing happened in there?
That's the million-dollar question. And it really helps us narrow down the possibilities. One option is that they had a wedge resection. It's where they remove a small, kind of suspicious section of lung tissue. It could have been a benign growth, something totally harmless, or even a very early stage malignancy.
So VATS helped them diagnose what was going on.
Exactly. And if it was a small section, the rest of the lung can compensate just fine. Breathing's no problem.
Gotcha. What else could explain the normal breath sounds?
Could have been a lung biopsy, taking a small sample of lung tissue to figure out what's going on, especially when other tests aren't clear. Again, taking a small sample wouldn't usually cause any noticeable breathing problems afterwards.
So wedge resection, lung biopsy, those are on the table. But what about something, well, more serious, like a lobectomy? Ah, now a lobectomy. That's removing a whole load of the lung, usually reserved for, well, more advanced diseases, often, smoking related. It's a bit less likely in this case, especially with those normal breath sounds.
But couldn't it have been a lobectomy just like years ago? And now the remaining lung has just, taken over, made up for the lost lobe?
It's possible you're right, we can't completely rule it out, but it does seem less likely given the other clues. Now, there's one more possibility we should consider. Might be the key to cracking this whole thing open.
Lay it on me.
Pneumothorax.
A collapsed lung. Now that sounds serious, but wouldn't a pneumothorax, well, even after treatment, shouldn't it cause some breathing problems?
It can, yeah, but not always. If it was treated properly and the lung healed well, the patient can breathe perfectly normally again. It all depends on how severe it was and how it was managed.
Okay, so pneumothorax is definitely a contender. Walk me through this. What happens when a lung collapses? Like, what's going on in there?
Imagine the lung like a balloon. A pneumothorax is like a tiny hole in that balloon. Air leaks into the space between the lung and the chest wall, so the lung can't expand properly.
Makes sense.
It can be pretty dramatic for the patient, sudden shortness of breath, chest pain.
Yeah, I bet. So, what happens when someone shows up in the ER with a suspected pneumothorax? What do you do?
It's all about quick action. First, got to make sure their airway's clear, they're getting enough oxygen. Then, got to figure out how bad the pneumothorax is. If it's a small one, sometimes it resolves on its own. Just observation and oxygen.
Okay, but what if it's a larger pneumothorax or they're really struggling?
Then we need to intervene. One option is to aspirate the air. Basically, use a needle and syringe to suck the air out of that space, let the lung reinflate.
So, like, patching up that hole in the balloon analogy.
Exactly. But sometimes aspiration isn't enough. Then we need to insert a chest drain.
A chest drain, what's that like?
The tube, inserted between the ribs, goes right into that chest cavity,
Uh-huh.
lets air and fluid drain out, gives the lung space to re-expand.
So either suck the air out with a needle or let it drain out through a tube. Sounds, well, pretty straightforward, right?
It can be a bit more nuanced than that. Different types of drains,
Mm,
and, well, the management depends on the size, the type of pneumothorax. We usually avoid using suction with the chest drains.
really? Why is that? Wouldn't suction, I don't know, get the air out faster?
It might seem counterintuitive, but suction can actually cause a pretty serious complication.
Ugh.
REPE, re-expansion pulmonary edema.
REPE. Doesn't sound good.
It's not. Think of it like this. You got a deflated balloon, right? You try to inflate it too quickly. What happens? The rubber, it weakens. It might even tear.
Okay, I'm seeing where you're going with this.
RDPE is kind of like that, but with the lungs.
Yeah.
Reinflate a collapsed lung too fast can cause fluid to leak into the lung tissue, makes it really hard to breathe.
So it's like a balancing act. Got to get the air out, but not too fast.
Exactly. Careful monitoring, adjusting the chest drain settings. Want the lung to re-expand gradually on its own time.
Man, this pneumothorax treatment is, well, it's more complex than I thought. So when does a collapsed lung actually require surgery? Like, when does VATS come into play?
That's a great question. And, well, that's where we'll pick things up next time.
All right, listeners, we've laid the groundwork for our investigation today. We've got our clues, we've explored VATS, and we've even learned about the delicate dance of pneumothorax treatment. What's standing out to you so far? What questions are bubbling up? We'll be back soon to unravel the mystery of why our patient needed VATS. Stay tuned.
Welcome back to our deep dive into the world of VATS. Last time, we were trying to figure out why a patient with perfectly normal breath sounds have this procedure. Explored a few possibilities, like wedge resection, lung biopsy, but we left off on a bit of a cliffhanger. When does a collapsed lung, a pneumothorax, actually need VATS surgery?
Yes. That's where things get even more interesting. For a first-time, uncomplicated pneumothorax, surgery is not usually the first choice. We typically try the less invasive stuff first, like aspiration or chest drains. Right, right. We talked about those options. But when does VATS become the go-to for pneumothorax?
Well, one scenario is when the pneumothorax keeps coming back,
Mm.
like a stubborn leak that just won't seal itself.
So it's not just fixing the current collapse, it's preventing future ones.
Exactly. And there are a few different VATS procedures that can help with that. One's called talc pleurodesis. Ever heard of that?
Talc pleurodesis, I feel like I've heard of it, but I can't quite place it. Remind me.
Think about how baby powder absorbs moisture. Well, in talc pleurodesis, they introduce medical-grade talc powder into the chest cavity. Causes a controlled inflammatory reaction, basically irritates the lining of the lung and chest wall, makes them stick together.
So it's like creating a scar on purpose
Yeah.
to seal up that leak.
Precisely. It's a natural sealant. Prevents air from leaking into that pleural space and causing another collapse.
That's pretty fascinating. What other tools do surgeons have for recurrent pneumothorax during VATS?
Another option is a pleurectomy. It's a bit more involved than talc pleurodesis. They surgically remove a portion of the pleura, that membrane that surrounds the lungs.
Why would you remove part of the pleura? What does that do?
Well, sometimes the pleura itself is the problem. Might have abnormalities, weak spots, makes it prone to leaking. Removing a section eliminates those potential trouble spots.
Okay, so talc pleurodesis seals the leak, pleurectomy removes the leaky part. What was that third option you mentioned?
Ah, that's a bulectomy. Remember we talked about the pneumothorax being like a hole in a balloon? Well, sometimes there are weak spots in the lung tissue itself, kind of like little bubbles, called bullae. These bullae can rupture, cause the lung to collapse. Bulectomy removes those bullae, takes out the source of the leak.
Wow, so surgeons have a whole toolkit of options for tackling pneumothorax during VAPS. It really is a, well, versatile procedure.
It is. It's really revolutionized how we approach chest surgery. But, as with any procedure, it's important to weigh the risks and benefits.
Speaking of risks, you mentioned earlier that REPE, re-expansion pulmonary edema, that can be a complication of pneumothorax treatment. That sounded pretty serious. Can you unpack that a bit more for us?
Of course. REPE is a rare but potentially life-threatening condition that can occur when a collapsed lung is reinflated too quickly.
So it's not the collapse itself, it's how it's treated.
Right. Finding that balance, reinflating the lung but not causing complications. See, when a lung's collapsed, the blood vessels inside it, they get compressed, Reinflated too fast, it
Mm.
overwhelms those blood vessels, causes fluid to leak into the lung tissue.
And that fluid buildup, that's what causes the edema.
Yes. Like the lung is, well, drowning from the inside out. That fluid messes with the normal exchange of oxygen and carbon dioxide, makes it tough to breathe.
Wow, that paints a pretty vivid picture. So how do you prevent that from happening? It's like a real tightrope walk.
It is. Careful monitoring is key. Chest x-rays to track how the lung's re-expanding. Make sure it's happening at a safe pace. And this is one reason we generally avoid using suction with chest drains.
Right, because suction could reinflate it too quickly.
Exactly. Sometimes slower, more gradual is safest. And of course, if we see any signs of REPE developing, we got to act fast. Stabilize the patient, address that fluid buildup.
Okay, so RVPE is a real concern, but sounds like doctors are equipped to manage it. I want to go back to our mystery patient for a sec. We've explored a bunch of VATS procedures, but we're still missing that last piece of the puzzle. Their breath sounds are normal, which just makes it, well, trickier.
It does. It could be the procedure was done a while back, lungs have fully recovered, or it could be a case where, well, only a tiny bit of lung tissue was involved. Breathing's unaffected.
Still in detective mode here. What other clues would be helpful?
Knowing the patient's age, medical history, that would help. Younger patients are more likely to have primary spontaneous pneumothorax. No apparent reason, just happens. Older patients, especially smokers or with lung disease, they're more prone to secondary pneumothorax. There's an underlying lung condition causing the collapse.
So the context really matters. It's not just about the procedure, it's the whole patient.
Exactly. And if we knew the type of pneumothorax, we could make more educated guesses about the VATS. Was it a recurrent one? Needed a more permanent fix? Was there a bulla that needed removing? Those details would give us a much clearer picture.
It's like those medical shows, you know? Got to piece together all the clues, figure out what's going on.
It is a bit like that. But instead of a crime scene, we're, well, exploring the landscape of the lungs. And speaking of exploring, there are some really incredible advances in lung imaging, helping us get a much clearer view of what's happening inside the chest.
Oh, right. We talked about that earlier. You mentioned some pretty high-tech stuff like EBUS. Can you explain what that is, how it's changing things?
EBS, that's endobronchial ultrasound. It's like having a tiny ultrasound probe on the end of a bronchoscope. A bronchoscope is this thin, flexible tube. We put it through the mouth or nose, down into the airways. With EBS, we can see and even biopsy lymph nodes, other structures, deep in the lungs.
So it's like having eyes and hands inside the lungs.
Exactly. And it's much less invasive than traditional biopsies. Those often needed surgery. EBUS, we get those tissue samples with minimal discomfort.
That's incredible, like science fiction, you know? What other cool tech are you guys using these days?
Another one that's really exciting is electromagnetic navigational bronchoscopy. It uses electromagnetic sensors and 3D mapping. Guides the bronchoscope to really specific spots in the lungs, even tiny, hard-to-reach areas.
So it's like a GPS for the lungs.
Exactly. We can reach and biopsy even the smallest lesions, incredibly accurate. It's really transforming how we diagnose and treat lung conditions.
Wow, I'm blown away by how much things have changed. It's making these procedures safer, less invasive, and, well, more effective.
It really is. And as research continues, we can expect even more groundbreaking stuff in the years to come.
It's an exciting time to be in medicine. All right, listeners, we've gone deep into VATS, explored pneumothorax, even glimpsed the future of lung imaging. Haven't quite solved our mystery patient's case, but I think we're, well, getting warmer. Stay tuned for the final part where we tie it all together and uncover some key takeaways from our deep dive. Welcome back to the deep dive.
You know, wrapping up our exploration of VATS and pneumothorax, it's amazing how much we've covered.
It has been quite a journey from those mysterious scars to, well, to cutting-edge lung imaging.
We learned about different VATS procedures, the intricacies of pneumothorax, even those potential complications like REPE.
Yeah.
But let's bring it back to our mystery patient. We know they had a VATS, their breathing's normal now, and we've gone through a lot of possibilities for why.
Even without knowing the exact reason, this deep dive's given you a much deeper understanding of, well, lung health and the advancements in how we diagnose and treat things, for sure. What are some key takeaways our listeners should keep in mind, especially if they encounter a similar case or just, you know, want to be more informed about their own lungs?
One thing that really stands out is context. Can't just look at the scars, the normal breath sounds in isolation. We got to consider the whole patient, you know, medical history, age, smoking, any previous lung issues. It all matters.
Right, like you said, it's about understanding the whole patient. If this was a pneumothorax, knowing if it was primary or secondary, that'd make a huge difference in understanding the VATS.
Absolutely. Primary pneumothorax in a young, healthy person might be treated conservatively, but a secondary pneumothorax, someone with underlying lung disease, that might need a more aggressive approach like VATS.
Like a medical puzzle. Each piece gets us closer to the solution.
I like that. Another key takeaway for me is that VATS, as minimally invasive as it is, as quick as the recovery is, it's not without risks.
Right, we talked about REPE, that scary complication, reinflating the lung too quickly. It's a reminder that even with, well, all this fancy technology, careful monitoring is still so important.
It is, and it highlights how important communication is between doctors and patients. Informed consent, making sure patients really understand the risks and benefits before going ahead with anything.
It's all about making decisions together, doctor and patient, finding the best path.
And remember, this deep dive, we've just scratched the surface. Medicine's always changing, new research, technologies, treatments all the time.
That's what makes it so fascinating. Always something new to discover, always more to learn.
So stay curious, ask questions, and never underestimate the power of knowledge when it comes to your health.
That's great advice. Well, I think we've successfully navigated the complexities of VATS and pneumothorax, uncovered some insights, sparked some curiosity.
It's been a pleasure diving into all this with you.
And a huge thanks to you, our listener, for joining us on this deep dive. Hope you've gained some valuable insights and a new appreciation for, well, for the complexity of lung health.
Until next time, keep exploring. Stay curious.
That's a wrap on this episode of the Deep Dive. We'll see you next time for another fascinating exploration into the world of knowledge.